Hi, my name is Erik DeRoche. I own Performance Health Northwest here in Bellingham, Washington, and I'm a sports chiropractor. Been practicing for 13 years now. We're in the COVID lockdown situation, so my apologies for background. I'm in my mother-in-law's house, seeing as how I have a 7.5-year-old daughter who is rather, how do I say this, loud. And wouldn't have the privacy there that I have here. So you'll see some pictures that don't look like they might go in my house, but here we are. Anyway, I was asked to do this by Theron Irish. He's been a friend and colleague for decades now. And I taught a class actually at Walken Community College last year regarding sports soft tissue therapy. Obviously, I'm a chiropractor, I'm not a massage therapist, but I kind of specialize in the treatment of musculoskeletal disorders, acute and or chronic. Also have a background in strength and conditioning, so I think it's important to be able to not just focus on the injury at hand, but also to prevent the injury in the future and to truly heal the athlete or individual wholeheartedly without just focusing on pain management. Not a pain specialist. I don't treat pain. I treat the person, and we try to get the person to perform better, function better, as opposed to just focusing on pain. I have an issue. I should say I take issue with treating pain. I get it. I understand it is an objective measure we can use using an MVOS or what have you. But I like to really focus on performance of the person, and I hope to at least maybe I guess elucidate. What's the word I want to use? I guess expound upon that during this brief presentation today. I was as far as a little bit about myself. You already know that I work for I own Performance Health Northwest. I grew up as a swimmer, so obviously shoulder injuries, shoulder issues were very omnipresent in the athletes on my team as well as myself. I went on to swim for a very, very short stint in college, and I was a very small fish in a giant pond in a Division I university, and I had anxiety when I hit the water, so that was fun. But I quit swimming, and then I started working as an athletic trainer for several years at West Virginia University as a student intern. And then my senior year, I was a strength coach with the football team, basketball team, men's basketball team, swimming, cross country, soccer, and track and field. That was my senior year. Working with the guys going on to the NFL Combine was my primary job, which was kind of cool. I admit, looking back at that. And then I wanted to get a master's degree at the University of South Carolina in exercise physiology. And unfortunately there it was a little more of a public health slant as opposed to a sports performance slant. But it is what it is. After that, decided to become a personal trainer. I worked in Charlotte, North Carolina for 4 years as a personal trainer. And then after that, I moved to Portland, Oregon to attend chiropractic college at University of Western States. But interestingly enough, the way I practice now is essentially the exact way that I envisioned myself practicing, how many years ago now? 16, 17 years ago. Which I'm really kind of proud of that, to be honest with you. I think that, we grow as individuals, we grow as providers, but I think when we have a vision, it's nice to be able to stick to it. Obviously things change and morph, but I think my vision of treating the athlete, treating their performance, treating the individual who is a performer better, getting them feeling better, functioning better, and I guess self-sufficient is really what I try to strive for. So I've also worked with and traveled with the U.S. national swim team. All the guys you've seen on TV, I've put my hands on them, which is kind of fun. They are just like you and me, except for they're really fast in the water and they happen to put the pants on one leg at a time, just like us. But incredible group of people, and it's been a lot of fun to work with them. I haven't worked with them in a couple of years now. It is a volunteer experience working with the U.S. Olympic Committee and or the national governing body of USA Swimming and many of the other NGBs, they call them national governing bodies. It is a volunteer experience, and then traveling and working at the Olympic Training Center in Colorado Springs, Chula Vista, California, or in Lake Placid, New York, or even Park City, Utah. Those are all volunteer stints that you would do, opportunities you would have to go and work there for a week or two. Then you get to experience working on, you name it, athlete, which is pretty cool. Admittedly, anybody who's a resident athlete at the Olympic Training Center, you have the opportunity to meet and work on, which is pretty. I'd say it's great. It's a great experience. I really loved it, and it's definitely kind of shaped who I am and shaped who I am as a provider. But now I definitely focus on the people of Bellingham, and it's been a really great place to work and live. And I hope you guys enjoy your stint as students as well as into becoming professional massage therapists. So that's just a little intro. But till today, as far as the topic today, without me rambling on, I've already taken up more of your time than you probably wanted to. But as far as the subject matter for today, I really want to talk about shoulder pathology and soft tissue work. And I'm not going to go into the weeds too much. My hope is to give you some information that you can use on a daily basis. That you're going to, hopefully, if you can glean just one or two things from me today. My hope is that you'll be able to perform those things in your own practices as well as on the students when you're practicing now in school. I'm a practical guy. If I can use it, I like it. If I'm just listening to someone ramble and I'm not learning anything, it's a waste of my time. So my hope is to give you some information that's practical. Practical skill application is huge for me. So that's what I'm gonna focus on today. I'm not going to focus on numbers. I don't think numbers are really that helpful except for maybe an insurance form. And we all know how wonderful they are to fill out. I'm not a huge fan of them myself. Knowing numbers as far as, let's say, the shoulder, for example, shoulder flexion, shoulder abduction, extension, internal rotation, horizontal adduction, those are important numbers to know, kind of. Be honest with you, I use more of the qualitative movements or qualitative information. I look at how they move. I might even videotape them. I'll use my iPad that I'm using for you right now or my iPhone, and I will actually videotape the person moving, and then from there, make a decision as to what happens and be able to show the athlete, show the person what I see so they can see it as well. Vast majority of the time, an athlete or a person has never seen how their shoulders move, or I should say how their shoulders or part of their body doesn't move appropriately. So I think that's really good information. So as far as the assessment's concerned, obviously a really important to start off with, I'll kind of start from the beginning here, obviously a SOAP note, right? So you have the subjective, objective, action, and plan. The subjective is really important. I think getting a really good history is important for any practitioner to try to define what is occurring, what has happened, what the perturbation or the stress was that created the injury. Was it a chronic issue? Was it an acute issue? Did it happen with an accident or trauma? Or did it happen over time? And then what activities does that person like to do and enjoy doing? And then figuring out what we can do on a regular basis in the clinic as well as at home to ameliorate those symptoms. So you can get more of your information actually talking to the person than you can by putting your hands on them. At first anyway. I've made more decisions as to how I was going to treat somebody by just talking to a person and getting a history from them than actually putting my hands on someone. I know that's kind of odd to see or to think of or to hear, but when you listen to a person, asking the right questions is really important. So make sure you listen to your instructors about taking appropriate histories if you're going to be kind of going down the road of injury massage therapy and treatment massage therapy. Obviously, that's one side of things. If you're in more of the spa massage, there's nothing wrong with that either. There's also a place for that in helping a person function better, feel better, emotionally, mentally, physically, etc., and just kind of helping them be grounded. Those are all effective treatment modalities too, but still getting a history and finding out how you can help, because we also have to know or realize our scope of practice as well. We're not going to try to overstep our scope of practice and do something we shouldn't be doing. But anyway, so history first. Make sure you ask the right questions. I think we've already gone over a little bit of that. Objectively, I think what's really important to note here is that objectively, I think you can really start off with keep it simple. Think about the things that a person's telling you, the subjective, and say, let's say, for example, they come in and they say, it hurts every time we'll use swimming, for example. Every time I take a stroke with the swimming, every time I take a stroke, my right shoulder hurts. We'll use right shoulder, for example, my right. Every time I put my hand in the water and pull, I feel pain right there. And they'll point to it 9 times out of 10. And you think anatomically, what is there? Why would that person be in pain right there when they press into the water? And we're not asking you to diagnose. I know massage therapists, we're not able to diagnose. But then you have to think, okay, if it hurts with that, then you say, what can I do in the clinic that may actually be able to reproduce that same motion, that may actually be able to reproduce their symptoms? So keep it simple, folks. A push-up. If they can do a push-up, if they can't do a push-up on the floor, can they do a push-up on a counter or on your massage table? Can they do a curl of some sort? Can they, if it's lower body, for example, can they do a squat? Can they do a deadlift? Can they do a reverse lunge, a forward lunge, a lateral lunge, a pull-up, a chin-up? So chin-up, pull-up. Lat pull-down, reverse grip pull-down. If you have these pieces of equipment, can they do band exercise? If you have bands in your office, if you do any exercises at all, using a band or something like that, having them try to reproduce their symptoms using certain motions, and then you can kind of take that motion that they just did and then think about what structures are under load. And then, okay, so is it with a stretch, does the tissue become painful? Or is it upon contraction, does that tissue become painful? So when I mean stretching, is it elongating? Or when they're contracting, is it shortening? It kind of tells you about what structures may be under load and when. And also, look, watching them perform a push-up, you can actually see the quality of the motion in the shoulder blades, the shoulder girdle, where the shoulder blades, are they up towards your ears and do a push-up this way? Are they using their arms as the major movers, or the shoulders as the major movers? Are they actually able to engage and rotate, retract, and depress the shoulder blades in order to be able to perform a proper push-up, to use the pectoralis major and minor, which are the muscles that should be doing the work when they perform a push-up. Looking for things you're looking for there are what structures are doing the work, are the appropriate structures doing the job, and are they experiencing pain with that position or with that movement? And trying to figure out what things are under load is probably going to be the most difficult part here, because you're not in school to become diagnosticians, you're in school to become massage therapists. But I think that aspect, that differentiation will, if you can become better at determining what exactly is occurring, you're going to differentiate yourself in your community wherever you choose to practice. And you're going to be able to, instead of just being the person someone shows up to get rubbed, instead of that, if you can actually determine the injury, determine what structures are under load, document them, and maybe even have a discussion with the referring provider or other providers who have a different skill set than yourself, and maybe that person hasn't gotten better. Let's say, for example, they've seen you 6 times, and by then the person's feeling the exact same way. Who can they see next? Do they need to go to imaging? Start off with X-rays potentially, MRIs. Diagnostic musculoskeletal ultrasound is another thing. I think it's really on the up and coming here in Bellingham, especially. It's been around for a long time, but just now we're really starting to use it a lot more. It's a great way to ascertain soft tissue pathology. Not great for certain things in the shoulder, like a capsular tear, for example, a labral tear, but quite good at trying to ascertain whether or not you're dealing with a rotator cuff pathology. So that's a couple things to think about. Okay, so we're kind of going over the objective. I made a couple notes for myself here. So as far as sport specific needs, I think what's really important with the sport specific needs is that every sport has its own chronic traumas, chronic micro traumas, macro traumas, things that occur. We know in football. Let's take football for example. You're dealing with big behemoth men hitting each other at astronomically fast speeds, creating huge forces, and one's absorbing more than the other. And you can kind of look at the mechanism of injury. It takes back to how did it happen? What was the mechanism of the injury, which is really important to ascertain here. So football is one. Think track and field. We know with track and field, if you have a mind for running, are they a sprinter? Are they a long distance runner? Are they a thrower? Are they a jumper? Are they a mid distance runner? And trying to figure out, okay, they have let's say a proximal hamstring strain. That's a hamstring that's closer up towards the buttock at where the hamstring originates at the ischial tuberosities. Let's say, for example, they've been told they have a hamstring strain at that area, and then you ask them questions about how did this happen. If they have a proximal hamstring strain, there's certain parts of the gait cycle that we have to think of as well. So let's think of coming off the blocks. Coming off the blocks, let's say it's your lead leg is your right leg, your trail leg is your left, obviously, and you're pushing heavily off your lead leg and you're driving off the blocks. So your hip is in flexion, and obviously we know the hamstring is a two-joint muscle, so it extends the hip and it flexes the knee. So this is where anatomy and kinesiology kind of play a little bit role here too. So if extending the hip and flexing the knee at the same time, which is basically coming off the block hard, could that strain the hamstring? Yes. And if you ask them, did it hurt on the start? If they say no, okay, let's talk about, did it happen during the acceleration? We know that an athlete reaches their top speed around 40 yards into a 100-meter dash, if they're a sprinter, for example. They reach max speed at 40 meters, and then they're at full speed. That's why they use 40-yard for the NFL Combine, by the way. They want to know acceleration, not necessarily top speed. So when you get to max speed, what are other tissues, or what part of that hamstring is going to be under load? If it's middle of the hamstring, we know that's more muscle belly, whereas a proximal hamstring is more muscle tendinous, right? A muscle belly or musculotendinous junction. And if it's distal, meaning down towards the knee, we know that's also tendon. Distal down toward the knee would mean to me, if they're a sprinter, that they're overreaching and they're pawing back. Their leg is hitting the ground, they're pawing backward, their hamstring is under load. If it's in the middle of the hamstring, it's probably because they either weren't warmed up enough or they were trying to push too hard. They were straining when they were running. So these are the things that you can kind of play with a little bit in your brain to figure out mechanics, and just looking up on YouTube or anywhere you want to go find out mechanics of the sport of the athlete you're working with. And if they're doing an intake form prior to their arrival, you can figure out what sport they play, what activities they enjoy, where the injury is, and you can try to get a better idea of who they are as a people. And after a while, you'll pretty much know these things. And some of the things I might have already said to you might sound foreign to you, but it comes in time. So don't get too freaked out. And I know I'm kind of speaking a lot of specifics here, but these specifics get easier. I promise you. Okay, they definitely get easier. So let me turn the light on here. Okay, now sorry about that. My apologies. So let's go back to the shoulder. I know I'm here for the shoulder. We kind of started talking about the hip. But I think importantly to think about would be misconceptions regarding shoulder mobility versus stability. We have to think about where the shoulder girdle attaches. We have to think about what structures attach to the shoulder, and the muscles of the shoulder girdle, they attach on the spine. We'll say thoracic spine and cervical spine. And if we think about it, if we were to look up and see where the latissimus dorsi attaches, it's attached to the iliac crests, right? So the latissimus dorsi, we know, extends the humerus and it internally rotates the humerus, right? So this kinesiology again, folks. Now, if we only think muscles, we're going to miss out a little bit, right? If we only think joints, like many of my colleagues only think of the joint structures, the skeleton, and they adjust the joints and they say everything's going to be great. But unfortunately, unless you do both, a lot of times you're not going to get the full Monty. And I will admit, I think that if we do more soft tissue work, which is 99% of my practice, we'll say 95% of my practice, if we do more soft tissue work, we will actually get better results. We'll actually get better results. Okay. Now, I take a brief break. There was a crazy noise bothering me there. So you have to think not just of one structure. Like you have to think about how these things relate to one another. So if you see an athlete during your objective study, they come in and say, I can't put my hands over my head. And they literally do this to that. You have to think, okay, what muscles, because you're a massage therapist, you have to think, what muscles can I work on that are going to help this athlete be able to reach overhead? So we automatically know. We know if a person can't come up this way, their lats are tight. The teres major is probably tight as well. Maybe the lower trapezius. And then we can start going in the weeds a little bit here. We start talking about the lumbar spine. We can start talking about the hips. We can start talking about the hip flexors. I mean, you name it. There's a lot of stuff here. But I think, too, we have to also think, what are other things that can possibly happen to the shoulder? And that if the shoulder blades, if a person sits at the desk for most of their career and their shoulder blades are elevated and protracted, right? So they're like this, and they're like this on their computer, and their head's forward. Right? So they're like this. This is them all day long. So what we automatically know, deep neck flexors are inhibited. Extensors of the neck become excessively tight. Trapezius and levator scapulae are elevated. Pectoralis major, pectoralis minor are tight, drawn this way. You're internally rotated here. We can always see people that sit like this all the time. Like, oh, your shoulders are. Well, how'd you know? Well, because how you sit, pretty easy to see. Now, so this is where it kind of gets a little bit muddier, right? You start thinking about, oh my gosh, there's all these things that I don't know. But once you look at how a person moves and start thinking about what may be inhibiting their range of motion, then you put your hands on it, right? Then you put your hands on it. You start figuring, okay, then you have them bring your arm up in this position, and you start feeling where they might feel the tension. And if you put pressure right here, like, oh, really tight right there. Okay, you mark that in your notes as far as what you're going to work on, right? Same thing with the lower back. Just think about relationships, not just where the pain is. I think that's one of the biggest things. If I can bring anything to you, don't think about just where it hurts. Because I can't tell you how many times I've had athletes walk in, they say they have a rotator cuff tear, they've been diagnosed with a rotator cuff tear, which is great. You know, well, it's not great, but I'm glad they have that diagnosis. I have a 50% tear in a supraspinatus tendon, right? So we know that's the superiormost rotator cuff muscle in my right shoulder. So if I have a 50% tear in that supraspinatus muscle, do I only focus on that muscle during massage therapy? No. Why did the supraspinatus become under load? Because I was internally rotated, I was elevated with my shoulder blades, and every single time I took a swimming stroke, I couldn't retract and depress my shoulder blade enough in order to get the catch, in order to get the big muscles in the back to do the job, and therefore I had a shoulder impingement, partial thickness tear of the supraspinatus tendon. Excuse me. So I think you're following me. I hope you're feeling me. I wish I could talk to you. I wish I could see you. I wish I could answer questions right now, but I can't. So I think don't necessarily just say, okay, where's the pain? I'm going to focus on where it hurts. Focus on the other structures around it, and think about why that tissue may be under load. Okay, it goes back to your initial assessment when you're doing the objective assessment. When you look at a push-up, when they do this position, what structures are under load? Long head biceps, where the long head biceps attaches to the labrum, right? What else is under load with this? Deltoid, anterior deltoid, and pec. Usually anterior deltoid. I've never really had problems. Too many people with the anterior deltoid problem. Mostly it's pec, long head biceps, transverse humeral ligament, which is the ligament that actually holds down that long head biceps. Actually holds it down, holds it in the groove called the intertubercular groove. So those are all things we have to think about. Why would this structure, why would this position cause pain, right? And then think about why is that tissue under load more when it's up this way versus down this way, right? Because the proper muscle tissue is going to be able to do the job when my shoulder blade is retracted and depressed, and I'm able to adduct the humerus and come across, versus if I was up this way and doing a push-up this way. Of course, this tissue is going to take all the stress. Of course, I'm going to be in pain. Of course, they're going to need to see you a million times, okay? Which is great for your checkbook or your bank account, but it's not great for the patient, okay? So think patient first, patient first. Now, regions of pathology, we've already kind of glazed over it a little bit, but in the shoulder in particular, I will tell you this. I really try to focus most of the time on shoulder girdle, not necessarily just the rotator cuff or just the long head biceps or just the transverse humeral ligament or just that little pain they have right there in the levator scapulae. You're in your careers, I promise you, if you're seeing 20 patients a week, 5 of them are going to come in and say, I have this little spot right here. If you just push on this, it hurts every single time. Instead of focusing on just that, think about why it's happening. What is the cause? If you can get rid of the cause, you'll be their best friend and they're going to get better and they're going to send all their friends to you too. All right? So focus on getting the patient better by figuring out causal relationships, not just treating pain. Okay? Most common thing in the shoulder you'll see is probably that levator scapulae origin, which is right at the root of the scapula. That's one of the first things you'll see. You'll see lots of upper neck tension, lots of tension headaches. People are going to call them migraines, but very rarely do I notice that people actually have a migraine. It's typically a cervicogenic headache and doesn't necessarily mean they need to be adjusted. It just means that what they're doing more times than not at home, while in the office, or what they do for occupation, or with their activity, riding a bicycle, being this way, these muscles get super tight, these muscles get inhibited, and their posture is crap, right? So if you can help their posture, give them give them ideas regarding a stand-up desk, Veridesk.com. I think you can get a desk for $250. Other couple companies that make desks as well for a little bit less than that, maybe $150, $200. But stand-up desk is huge. You do a stand-up desk, man, you're going to help a lot of people. So that upper neck pain here, or upper back, neck pain here, suboccipitals, even in the capitalis, which is something that not many people think of. The capitalis is a structure that's basically here to here, and in the middle it's more fascial relationships. And once it gets to here, it turns into the frontalis, right? So people sometimes get headaches above their eyes. Most of the time it comes from here, which is basically the origin of the greater and lesser occipital nerves that traverse through the triangle of suboccipital triangle with the 4 different muscles, and I won't name them because it's going to go one or the other. But those nerves come right up the back of the head and stop here, right? So if you can affect this area with your hands, manual therapy. Sometimes I use range of motion, which is we're going to get into a little bit today. Using your hands to kind of feel where those tissue spots are, and just doing some light pressure back there can really make everybody's day. Also, tight pecs is huge. If you can work on a person's pecs and loosen this area up, if you're a man working on a woman, just make sure you tell a woman what you're about to do, and get their permission. Of course, we have to make sure we maintain modesty and we maintain professionalism. So make sure you're very open with them and tell them exactly what's going to happen. If they give you this, go ahead, say, great. Obviously, you're not touching breast tissue, but you're going to be in the pectoralis tissue. Subscapularis is another big one, which is obviously well known. It's on the anterior side of your scapula. Runs up here and attaches on the internal, right here, and it internally rotates your arm, right? So if you sit all day long with internal rotated posture, 9 times out of 10, tight pecs, tight subscapularis, and then all the muscles in the back of the posterior rotator cuff, right here, infraspinatus, the teres minor, and then teres major as it runs down through, which isn't a rotator cuff muscle, as you well know. The posterior rotator cuff muscles, they kind of fight a battle in a way. So it's really not about like just focusing on that pain right there, like, oh yeah, dig right there. Well, thing is that those posterior rotator cuff muscles are small. Infraspinatus is relatively big, we'll call it relatively big. The teres minor is really small, but it's a really big hot spot when people get pain in their shoulder. And then people always want to have that worked on. I rarely do. I typically work on the stuff in front. That'd be pectoralis major, the pectoralis minor, and subscapularis. The reason being is that when a person, let's say for example, a person's going to throw a ball and they come up into the cocked position, which is external rotation, abduction, and extension of their humerus, when they come and follow through, the pectoralis major and subscapularis are doing a lot of work to internally rotate the humerus and adduct. But the thing is that you've got two muscles back here that basically try to stabilize that glenohumeral joint. And those external rotator muscles are literally trying to stop you from your arm throwing off your body. I mean, it's kind of extreme, mind you. But if you can work not just on the stuff that hurts, like we've earlier mentioned, work on the stuff in front to loosen this, loosen this, loosen this, so that when they go through, these muscles are healthy, right? That's one of the biggest things I'd like to really emphasize to you is that healthy tissue moves well, healthy tissue heals, healthy tissue can stretch, okay? You can't stretch unhealthy tissue. Unhealthy tissue can't get stronger, so you could strengthen there until the cows come home. Some of these soft tissue structures that have pathology, it doesn't make them better long term. So really focus on soft tissue health. That's basically bringing blood flow. Your job is bring blood flow back to soft tissue so that they heal, so that the range of motion is appropriate, and so they have appropriate muscle action, muscle activation, so that the nervous system has something to do with it. It can do something with it instead of just being this big ball of fibrous tissue that a person's trying to stretch. The cows come home and try and do their internal rotation, external rotation band exercises, which I literally have never prescribed. I just don't do it. I worked with a couple people in the biz, and we have lots of discussions about internal, external rotation band exercises, and we just don't prescribe them. We just don't do it. There's so many other things you can do for the shoulder girdle. The big muscles of the back, the big muscles of the shoulder itself that basically stabilizes the big structures so that the little guys don't have to do the work. If the little guys are doing more work than they can handle, they will get injured and they will come in to see you more than they should. So kind of think of these things a little bit, okay? Now, as far as what an LMP, LMT, however you want to call it, should focus on, I think we've kind of already alluded to a lot of it. I'm not going to bore the snot out of you anymore. I think I've already taken up a lot of your time. But I think really, once again, let's review a little bit regarding what an LMP and how an LMP can kind of fit within the construct of manual therapy within the sports performance world, and obviously I'm more than happy to discuss anything with you guys at any point in time. I'll at the end of this I'll give you my contact information so we can talk, and we can ask me anything you want. But I think communication with other providers is really important. Making sure that you're not trying to diagnose things, as you well know. Making sure you're not trying to work above your pay grade. Giving certain advice may not be appropriate, but at the same time, you guys are with a person for an hour, hour and a half, maybe 2 hours sometimes. So you have with that is a lot of power, okay? So I want you to kind of take that to heart, and they're going to listen. Your patients are going to listen to you, and if you're giving good advice, they're going to get better. Just make sure that you're not going above and beyond where you should go with things. But make sure that you also have contact or connections with other providers in your community or people who have referred that patient to you, whether it be a physical therapist, a PTA, a medical doctor, chiropractic physician, anybody who has sent them to you. Make sure you if you have a question or if you have a good working relationship, maybe send that provider an email saying, hey, this is what I found. This athlete, to keep it short, keep it simple, doesn't have to go in the weeds, doesn't have to go anything crazy. Just to the point, say, this is what I found, this is what I'm treating, and thank you for sending this patient in. Keep it short and simple, and that is going to go a long way, I promise, into not only getting referrals for the future, but also to gain confidence in the providers that are sending people to you. If that's any advice, I hope that's taken to heart a little bit. That works exceptionally well, at least as far as the people I've worked with in the past. But other things that I want you to know would be specific I guess, soft tissue modalities, soft tissue treatments that I use. Most everything I do is with range of motion. I never, yeah, I can say never. I never perform soft tissue work statically. Yeah, I might use a hypervolt vibrocussor kind of massage gun to kind of loosen tissue up if it's really solid and really stiff and a person just needs to chill. But most of the time it's with range of motion. So think about the range of motion of the muscle. Think about what that muscle's action is. And this is where kinesiology kind of comes into play. So those of you with a kinesiology background will do better with this part. But those who don't have a kinesiology background, you may just want to kind of review anatomy. So this is basic anatomy. I mean, you know that. So just think about what the muscle does. Think about, we know that the lats internally rotate and extend the humerus, right? So this and this. So in order to elongate it, what do? We do this, right? We externally rotate the hand. Sorry, I can't see my thumb. We're externally rotating the hand, and we're flexing the shoulder, flexing the humerus, right? So how do we treat the lat? I personally would have them lay prone or sideline, depending on if they have another shoulder issue on the other side, if they can lay on their side. And I would place my hand at one of the insertion points of the lat, which is right there. And I can't really show you how I do it with my hands because I would come with an open hand. And I would take the tissue both superiorly as well as medially towards the spine, as well as inferiorly. And I work the entire area of that lat from where it attaches to the lateral, basically the angles, the apex of the scapula, down and or across to the thoracic spine, down all the way to the iliac crests. And if I can work the entire structure of the lat, what do I do when I'm done working on that tissue? I have them move the shoulder again and have them go up into full flexion. If they can move into full flexion, I did my job, right? And then you look like a hero, which is kind of cool. All right, so that's the lats. Subscapularis. Let's go over a couple of them, just to kind of give you an idea. I would have the person lay on the back. I would take my thumb right here in the subscapularis. I would take my other hand and I would just guide their arm into external rotation, extension. Okay, come from here, let's go up into extension, external rotation. That's all we'll do. All right, instead of just kind of digging on it. And you'll find spots that are really hot. Back off. Okay. The goal with soft tissue therapy, as you were probably well aware, is not to cause pain. I tend to be heavy-handed. I'm not sure if anybody know who I am. I tend to be heavy-handed. I tend to push. I tend to get in there. You might have heard me. Oh yeah, he gets in there. Yeah, I do. The goal though is improving a range of motion, improving a function, improving performance. So sometimes athletes are going to be bound up. If they've never had anybody's hands on them, I guarantee you they're going to be in pain no matter what you touch. And sometimes that's good, sometimes that's bad. A runner, an old salt runner who's 55, 60 years old, that's not that old, not that much older than me, but a person who's been running for 40 years, has never had massage therapy before, they're going to feel like beef jerky. Their tissue is going to feel like beef jerky. You just put your finger on it and it's just like, oh my gosh, you're looking at a calf muscle, for example. Versus an athlete who's 18 years old, swimmer, they're going to be very supple most of the time. So you kind of got to get an idea of these athletes. You got to figure out where you need to focus on too. So each athlete group that you work with, or I work with athletes, so we'll talk about athletes, but every swimmer you work with, you're going to have a certain subset of muscles. You know that you need to focus on breaststrokers. You need to focus on their hips and their adductors, because the breaststroke kick is the most important aspect of that stroke. Butterfly, what do you need to focus on? Most of the time it's lats, subscapularis, pecs, and lower back. Backstrokers, they need a lot of range of motion. So the range of motion that an athlete gets or needs is going to be assessed by you, and then you need to determine where are they deficient and then figure out the muscles that are inhibiting them from moving into that range of motion. Okay? Let's see here. I use active release technique. I think it's a very extremely effective technique system. It is not cheap to get the certification. I think I've spent about $10,000 on continuing education and active release, which is actually less than a lot of my colleagues. I did not keep the certification up. I think I did it for a solid 8 or 9 years, I think. And then I let it slide recently. I just didn't want to spend the extra money. The skill's still there, the mindset's still there, the ideology's still there, but I didn't keep up on the certification. I don't think you really need to keep up on certifications unless you really want the name brand behind you. Sometimes that's great. There's nothing wrong with putting your name on their website. Active Release actually has a part where they have a provider finder, find a provider section. They type in their zip code and boom, your name pops up. And I think in Bellingham there's only, used to be only 2. Now there's none because my name's not on the site anymore. But I still do Active Release. I just don't say I'm Active Release certified. I'm not sure if that's breaking any rules. And then other couple modalities I really like would be FDM, fascial distortion model, which is very similar to Active Release, I will say, and I think it actually has some great application for just the fascial component. And I think that's another thing that I didn't talk about yet, but I think fascia is really it's the not up and coming, but it is a part of the body that has been studied exceedingly in the last decade or so. And very importantly, fascia is obviously like the sausage casing of a muscle. It's kind of what holds us together. There's many, many layers between the fat layer and the muscle layer, and that's fascia. And in between the muscle layers, the intramuscular, intraseptal fascias, they can kind of get bound together if you wish. So if you can kind of think about not just the muscle itself or the tight spot, but how can those tissues move, or how should those tissues move across one another? Should just be jam on a tissue and grind it? Well, no, athletes need to have range of motion. So how does that range of motion occur? Between the fascial layers. So think of a hamstring, for example. You have the medial and lateral hamstrings. You have the biceps femoris, which is the most lateral and the most commonly injured hamstring tendon or muscle. And you have the 2 medial, the semitendinosus and semimembranosus. And then you also have one that most people say is a hamstring injury, but it's actually adductor magnus. It functions, the anterior portion is the adductor portion. The posterior portion is actually a hip extender. What other muscles are hip extenders? Hamstrings, right? So if that adductor magnus, the posterior portion of adductor magnus, which is innervated by the sciatic nerve, which is the exact same nerve that innervates the hamstrings, sciatic nerve, if the adductor magnus and the medial hamstrings are stuck together, you're not going to have adequate glide between those tissues. So you can actually take your hand and place your thumb or fingers in between the tissue and have the athlete move into a hip flexion and or abduction motion to actually get those tissues to glide across one another. It's not about how hard you push. It's about getting them to move across tension. Find the tension. So I'll give you a little hint here. Find the tension and move into the tension and try to move through it without causing undue harm and or excessive pain. I will admit the adductor magnus and hamstring tendons are very tender, and they're an area that is sensitive and is an area that you need to kind of tell athlete you're going to do because it doesn't feel good and it's in a very sensitive spot. But if you do it right, they're going to get off your table and thank you because no one's ever done it before. So think range of motion to get those tissue planes to move across to one another. Right? A little different than a sports, like a post-activity sports massage. It's more therapeutic massage, getting rid of the soft tissue adhesions and or those fascial plane adhesions that disallow that glide and slide across the tissues. Okay, so I think I bored you for a long time. My apologies so far, so I want you to think of other things too. So I want you to really think about how you can document. And I know documentation isn't necessarily a sexy thing to talk about, but again, go back to your objective. Figure out what you found out with the objective. Hurts with a push-up, hurts with going overhead. Can they get a full range of motion in the overhead? No, they can't flex to 180 degrees. So you can kind of make a general assumption. Okay, they're at 160 degrees of shoulder flexion or humeral flexion, however you want to document it. Their shoulder blade doesn't retract and depress. There's lack of lateral rotation, lack of medial rotation. There's excessive elevation, excessive protraction. Think of all these different terminologies you've already learned and then try to apply them to your objective measurements. And then when you're finished with the athlete or when you're doing your reassessment after, let's say, 3 visits, 4 visits, you have something concrete to look back to say, okay, like invariably an athlete will come and say, I don't think I'm better. Okay, we'll tell you why you're better. Well, my shoulder still hurts. Okay, well, let's look at some of the things that I found in the first subjective study, and we'll compare it to now. Say, okay, go overhead, and they're completely overhead with both arms. Does it hurt? No. How about internal rotation? Does it hurt? No. How about external rotation? Yeah, it hurts still a little bit right there. Well, last time you said it hurt at 160 degrees of flexion, and it hurt at, let's say, 25 degrees of internal rotation or 25 degrees of external rotation. And then now it doesn't hurt with either one of those, but it hurts a little bit with extension, abduction, external rotation. Oh, okay, I guess you're right. I'm almost better. I'm doing better. Okay, it's always good to be able to document at least a little bit of your results, not just for the athlete or to get them to buy in, if you wish, but to get them to understand that manual therapy is a process. It is not a come in and get the massage one time a year, or if they're doing a 100-mile ultra marathon. It doesn't mean come in the day before the race and expect you to be able to undo 6 months of training that has destroyed their body and get them to be able to run the next day. Right? This is not how manual therapy works. And don't let anybody fool you. It doesn't happen like that most of the time. Sometimes some miracles happen, but very rarely. What I want you to think of is that it is a process, and you got to tell the people you work with that it's a process, and you've got to kind of instill upon them the idea that they're trusting you to take the reins and making them feel better, so they have to trust you to learn who they are. I don't know about you, but like, you don't know me from Adam, and I don't know you from Adam. The first time I meet you. After 2, I start to learn a little about you. By the 3rd, I start to feel I'm pretty confident. And this is what I tell the athletes that I see. Give me 3 to 5 visits. And if I see significant change within 3 to 5 visits, I know we're doing our job. And then I want you to continue to come see me. If we get to that third to fifth visit, and you're feeling like you're lacking confidence in my abilities, if your condition has not improved at all, I will do one of 2 things. I will either change my course of action drastically, or I will refer you for whether it be diagnostic imaging or to a provider that will deal with things differently than I did. Okay? Most of the time, I will admit, we are able to figure out what is happening. We're able to gain the trust of the athlete because we have their best interest at heart. Okay? So, interestingly enough, when talking to Theron, thank you, Theron, for having me here tonight, tonight, whatever. When talking to him, we kind of talked about doing a shoulder presentation, but without a model and without having you here, without being there in front of you, it is difficult. So I'm going to give you a couple resources to use, possibilities that you can use. One of which, for anatomy in particular, it's called The Visible Body. It is hands down my favorite app that I'm going to try to pull it up on my phone here. Visible, I don't have it on my phone, I have it on my iPad, which I'm using right now. It's called The Visible Body, that works exceptionally well. I think it was $35, give or take. But it basically shows you range of motion, shows you origin, shows you insertion in different layers. I did download the musculoskeletal one. There's actually one for the internal organs, the viscera, as well as circulatory and nervous system as well. And then you can kind of layer it in and layer it out. You can actually look at the fascial layers and dermatomes and what part of the body is referred. When I push my infraspinatus, why does my wrist hurt? It shows you dermatomes. It shows you a lot about the nerves of the neck, innervations, what nerves supply, what muscles, etc., and skin too. But it might be a really good resource for anatomy. Obviously, physiology. There's a myriad different resources for that. As far as running mechanics is concerned, I would go with. There's a couple that go into the weeds pretty heavy. Franz Bosch wrote a book called Running. It is like an encyclopedia. That boy's about that thick, and it's a little thick. So make sure you have your favorite beverage and kind of dive in a little bit if you really want to talk about running mechanics. Sprinting, mid-distance, and long-distance running. Swimming mechanics, I would actually implore you to look upon usaswimming.org. Has really cool things on swimming mechanics. Just Swim I think is another one that I use a little bit. I've written some articles for a website called SwimSwam, and a couple others that I've done some work with for some of the guys. I work a little bit with Russell Mark. He's the head biomechanist, basically human performance guy at USA Swimming. If you would like me, if you want to ask me any questions at all on swimming or shoulder stuff, I'm more than happy to give you that information. I don't consider myself an expert. I consider myself a person who's worked on enough people to know better. I like to think anyway. Do I make mistakes? Yep, I do. And do I win all the battles? No, I do not. But I like to think I win more than I lose. And I hope that I can help you at any point in time in your careers, now, in the future, whenever. I am here for you. So please give me a call or email me. Email is drd, Dr. D, at performancehealthnw.com. And again, I own Performance Health Northwest here in Bellingham. And that's probably the easiest way. Just email me and I'll get back to you as soon as I can. But I'm going to post this up, and Theron's going to share it for you. And excuse me, Mr. Irish, I'm not sure what he goes by. But I look forward to seeing each and every one of you. Hopefully, when we get rid of this whole cacophonous mess of COVID-19, the co-apocalypse, I don't know what they're calling it. It's a sad state of affairs that we can't come in and see each other. But I'm glad that we can help you out in any way possible. So if you have any other questions, please let me know. And thank you for your time. Sorry to bore you for so long. Bye-bye.